So good evening, colleagues. Welcome to this week's tutorial. We'll be looking at capnography in anesthesia and intensive care. So I can see so my screen is not moving. Just bear with me. Let me see what's happening. Okay, so are you still seeing my screen now?
Yes, Prof.
Yes, Prof.
All right,
Yes,
so
Prof.
I'm on
Yes,
learning
Prof.
outcomes. We're looking at the basic, at the end of the tutorial, every participant should be able to explain the basic physics and physiology that underline the measurement of carbon dioxide levels in expired air. We should be able to describe the different phases of the capnograph. We should be able to recognize normal and abnormal capnograph patterns and what they mean clinically. Want to compare capnography and pulse oximetry, and want to be able to apply knowledge of capnography to real-life case studies, both in anesthesia and intensive care. All right, we'll follow this outline. We'll be looking at introduction, then clinical scenarios, definition, capnography versus capnometry, the principles of capnography, the uses, the types of capnography, abnormal capnography, then we'll conclude, and then our references. Yes, I remember that we talked about this case scenario last week, but we'll be answering the questions in different format. So what I want you to do is to just answer the questions. There are multiple choice or single based answer question. Just answer them on your own. Then at the end of the day, we will then look at what you scored. There are 8 questions from this scenario. So I'm going to read it. Then we'll go to the question session. Then you answer. At the end, we're going to look at you score yourself and know what you got. Okay. So a 45-year-old male patient undergoes general anesthesia for an emergency appendectomy. During the procedure, the anesthetist on duty noted a sudden drop in EtCO2 levels on the capnograph. This was followed by a change in the capnogram waveform. Simultaneously, the patient's blood pressure begins to drop and the heart rate becomes tachycardic. All right, so let's look at the first question. All right, just answer them somewhere, either A or to D. So the first one, what does a sudden drop in EtCO2 levels during surgery typically indicate? All right, no chorus answer, just write it down. You can type it in. Number 1, so what does a sudden drop in EtCO2 levels during surgery typically indicate? All right, are we done with first question? Second question, which condition is most likely to cause a sudden drop in EtCO2, hypotension, and tachycardia? 1 minute for each question. I hope we're attempting the questions.
Yes, Prof.
Okay. I can't see anybody typing on the chats. Number 3, what is the significance of a change in the capnograph waveform in this situation? A, suggests hypoventilation. B, indicates the ventilator malfunction. C, signals a potential respiratory or cardiovascular compromise. D, implies the need for increased ventilation settings. Number 4, Which immediate intervention is appropriate for suspected PE during surgery? Which intermediate intervention is appropriate for suspected pulmonary embolism during surgery? A, increase IV fluid and start inotropes. B, increase ventilator rate. C, administer diuretics. D, reduce anesthetic depth. Okay, I hope we are done with the 4 questions. Can I move to the next slide? Okay, I'm moving to the next slide, number 5. Sorry? I can't hear you. Increase your volume.
Few more seconds, sir. Let me get the 4th one.
The 4th one. Okay, let's go back to the 4th question.
Thank you. Okay.
4th question. It's not going. What's going on? My slide is not moving. My slide is not moving. James, my slide is not moving anymore. Oh my God, my slide is not moving.
Maybe continue going forward.
Okay, let's see number 5. Let's go to 5, 6. You come back to 4 so that let's see. So 5, what does a declining blood pressure during surgery indicate? Just read the question yourself, all right? I'll give you 4 minutes. 1 minute for each question. Are we done?
No, sir.
Okay. It's steeplechase, eh? You chase the question and you answer. It's steeplechase.
Yeah, what's it? Yeah. Thank you. Okay. Done.
Okay. All right. So
the third slide, Prof.
Sorry?
The third slide.
First slide.
I will have the third slide again. Yes. And something I would want to see on 3 or 4. I will set that.
Can you see my slide?
Okay.
Yes.
Okay, I've gone to the first 4 questions. Time up with the questions. Time up with the question. We did this last week, so let's quickly revise ourselves. Number 1, please mark. Number 1, the correct answer is B. Number 2, B. Number 3 is C. Number 4 is A. Number 5, the correct answer is C. Number 6, correct answer is 6. Number 7 is A. Number 7, no, I'm wrong. Number 7 is C. Oh, I think, sorry, let's go back. I think I made a mistake. Let me go back. Number 1 is B. Number 2, what conditions most likely to cause a drop in CO2? B. Number 3, what is the significance of a chain capnograph waveform in this situation? All right, C. Number 4, what immediate intervention is appropriate? All right, number 4 is A. Increase IV fluid and all that. Number 5, what does a declining blood pressure during surgery indicate about the patient hemodynamic status? B, worsening hemodynamic status. C, what is a likely cause of a sudden decrease in CO2 that should be ruled out beside pulmonary embolism? B, cardiac arrest. 7, what diagnostic tool could help confirm pulmonary embolism intraoperatively? The answer is C. And the last question is, what is the primary cause of tachycardia in the context of a sudden drop in CO2 and hypotension? The answer is C. So what did you get over 8, everyone? Anybody
7.
got 100% 8 over 8?
Oh, 7.
Some people got 7. Anybody got 8 over 8?
I got 6.
Oh, 6. Good.
7.
7.
7 too.
7. Anybody got 8? But those are excellent marks. The one that got 7, where did you miss? Maybe we can argue that answer. Which of the questions did you miss?
I missed number 4.
No time to answer number 4.
Number 4, what does number 4 say?
Also
Number 3, sorry, number 3. Time factor.
Number 4.
What did you choose in number 4?
Well, I didn't choose anything. I was still trying. Well, the answer has been look. I didn't choose anything. I was trying to decide.
Okay.
I thought maybe anything that had to do with increasing oxygen would be the answer. I don't know. Well, maybe the answer. I don't know.
Okay. All right. I saw some people got a Nosifo Magwaza got 8. Dr. Woke from Ethiopia got 8. Good job, guys. Good job. Okay. So let's continue with why is this thing ceasing? Okay, so let's look at this spot diagnosis. On the left is a shark fin. All right, we remember that. And this one is what? The coronary cleft. We talked about that. So let's go ahead today. So by way of introduction, capnography is a critical, essential monitoring technique, both in anesthesia and in the ICU. Its applications include, but not limited to, simple carbon dioxide measurement, but it also offers a comprehensive picture of ventilatory, circulatory, and metabolic status of the patient. So It's a one in all monitor, all right? And another advantage of it is that it typically detects changes in a patient's breathing before pulse oximetry. So before you see a change in your SpO2 readings, you will first of all see the EtCO2 changes. All right, this was done by a study. There was a study that found out that about in 70% of cases, abnormal EtCO2 results were observed before SpO2 changes, or even before observed hypoventilation. And this took about 30 to 60 seconds, almost 1 minute difference between changes in EtCO2 and SpO2 readings. So this underscores the importance of capnography in monitoring. All right, the WFSA, all right, in its bid to increase safety, came out with this stem cell surgery saves lives. And one of the ways to promote this was incorporating capnography, especially in low and middle income countries where you do not have access to comprehensive monitoring equipment. The same thing, the LifeBus project, many of us have been beneficiaries of LifeBus project with provision of Capnograph, all right? So the LifeBus project is a global initiative focused on improving safety of anesthesia and surgery, especially in low resource settings. And one of the ways they did it by incorporating capnography as a critical addition to anesthesia care in these settings. I hope all of us have access to capnography in our centers, all right, because this is what Safe Surgery, Save Lives, and the LifeBus project is all about. So before we talk about end-tidal CO2 measurement, let's look at, remind ourselves about the different methods of measuring the arterial partial pressure of carbon dioxide. All right, I have this mnemonics, cheers, so you don't forget. The C there is the carbon dioxide electrodes, and the commonest one is the Severingus electrodes. All right, this is what is used in most of our ABG machine, and it measures carbon dioxide using a change in pH in the bicarbonate solution. So we have a semi-permeable membrane that's permeable to carbon dioxide. All right, and the change in pH is noted, all right, and that is what is used to measure the PaCO2. We have the intravascular electrode and transcutaneous electrode. The transcutaneous carbon dioxide electrode is a non-invasive method that is used to estimate arterial CO2 levels, and it does this by measuring the skin carbon dioxide. Is beneficial, especially for pediatric and neonatal patients. Then we have the Harden apparatus, all right? This utilizes the absorption of carbon dioxide by potassium hydroxide from a sample of air. The remaining sample is measured, all right? And it is used to detect the loss of volume due to the absorption of carbon dioxide by potassium hydroxide. The difference in volume is therefore divided by the original volume, and this gives you the percentage of carbon dioxide that is present in the sample of air, all right? It was accurate, but you can see how gingetic and cumbersome it could be, so it has been replaced by more user-friendly technologies. But it's important that remember when we're preparing for part one, these are questions I usually ask. Then we have the Vance-like apparatus. All right, what this does is that it involves the chemical reactions with a sample of air which liberates carbon dioxide from blood. And the resultant volume of gas is measured, all right, to give you an idea of the PaCO2 of the sample of air. We have indwelling, the I stands for indwelling intravascular electrode, all right, although it's similar to the carbon dioxide electrode, but it's permanently positioned inside the patient's blood vessel. And this gives you a real-time carbon dioxide level monitoring. It is particularly useful in ICU settings for continuous measurement. Then we have the rebreathing technique of Campbell and Howell. All right. Here, the patient rebreathes carbon dioxide from a closed system that has a known gas measure. All right. The change in carbon dioxide over time is used to estimate the PaCO2. It's valuable in physiological studies of ventilation, especially in physiology labs. Then we have the Singer-Anderson nomograph. All right. This is a tool that is used to estimate PaCO2 based on blood pH. All right. So you have the Severus electrode and this one, and the nomogram is drawn. That is like a graph that uses the pH of the blood sample, all right, to estimate the PaCO2. Then we have the mass spectrometry. All right, what it does is like ionizes gas, analyzes its mass to charge ratio. All right, it's mainly used in research laboratory due to its high sensitivity and high cost. Okay, so having talked about the measurement of arterial partial pressure of carbon dioxide, let's come down to capnograph. Capnograph is one of the methods of measuring EtCO2. All right. And what does capnograph offer? It offers a real-time monitoring, all right, by quickly detecting respiratory changes, even before other signs or symptoms will manifest, like we mentioned, before any desaturation, before your patient will show any sign of desaturation or hypoventilation, capnograph will show you changes in your end-tidal CO2. All right, because of it, it increases patient safety during anesthesia and intensive care because it helps you to detect hypoventilation, airway obstruction, and also can be used to detect ventilation perfusion mismatches. Capnograph will also give you an early warning for airway or ventilatory issues. For instance, a patient, accidental extubation, all right, the capnograph will show you earlier than any other monitoring device. So capnograph is a non-invasive monitor of the respiratory, cardiac, and anesthetic breathing system. And it relies on the principle of absorption of infrared light by carbon dioxide, right? During the Second World War, this German bioengineer, Karl Luft, in 1943, was called in to help measure carbon dioxide in German submarine, all right? And so this guy, Luft, developed what he used to know as the Luft detector, which metamorphosed into the modern-day capnograph, all right? And this was based on the knowledge that carbon dioxide is one of the gases that absorbs infrared at a particular wavelength, which is about 4.3 micrometer. So for a single-based answer question, I could ask, all right, what is the wavelength at which carbon dioxide will absorb infrared radiation? That will be about 4.3 micrometer. In 1978, despite the fact that this originated from Germany, Holland became the first country to adopt capnography as a standard of monitoring during anesthesia. And over the years, this has spread to all other countries, including our LMIC, the low-medium countries. Now, EtCO2 serves as a surrogate for the partial pressure of carbon dioxide in the arterial blood. All right. So in stable patients, EtCO2 closely approximates PaCO2. All right, which makes it a reliable, non-invasive indicator of your patient's respiratory status. During ventilation perfusion mismatch, all right, like our case scenarios when the patient had a pulmonary embolism or shock, the gradient, all right, there's an increase in gradient between EtCO2 and PaCO2. So this can affect accuracy, all right, because of the ventilation perfusion mismatch. So the normal EtCO2 range is between 35 to 45 millimeters of mercury, all right? And like we said before, All right, EtCO2 closely approximates PaCO2 to the healthy lungs, or you can have what we know as the arterial EtCO2 gradient, which is about 2 to 5 millimeters lower. EtCO2 is usually about 2 to 5 millimeters of mercury lower than your PaCO2. All right, in our ICU, we have capnograph for all our intubated, ventilated patients. So even before we can get our ABG results, we can actually estimate the PaCO2 of our patients just looking at the EtCO2 values. So what are the factors that influence your EtCO2 levels? Likely mnemonics, by now you know, so just write EtCO2, all right? And one of them is elimination of carbon dioxide, all right? So through your hypo or hyperventilated patient. So when a patient has hypoventilation, this will lead to carbon dioxide retention, and this will obviously lead to increase in your EtCO2. For a patient who is hyperventilating, all right, there will be increased CO2 elimination, and this will lower your EtCO2 levels. Jesus. The T is transport of carbon dioxide in blood. That is your perfusion. All right, this relates with changes in cardiac output. A low cardiac output, for instance, will reduce the amount of carbon dioxide reaching the lungs, which will lead to a drop in your EtCO2. All right, then metabolism, which has to do with carbon dioxide production. Increased metabolic activity will increase your carbon dioxide production, and this will also be seen in increasing intertidal CO2. Reduced metabolism will decrease CO2 production, which will lower your EtCO2. All right, all I've mentioned here, there are here causes of elevated CO2, metabolism, respiratory system, circulatory system, even medications like your bicarbonate administration during metabolic alkalosis can also cause this, okay? All right, so interpretation, we'll mention some of these things. Let's move on because of our time. Now let's go on, we'll move on to, because of our time, let me see. Calibration of capnograms. Capnograms must be calibrated at least daily to ensure accurate readings. All right, and this is accompanied by zeroing the monitor to room air and then administer a gas of no concentration of carbon dioxide. Most mainstream capnograms are often equipped with calibration sample size with mixture of carbon dioxide and nitrogen. All right, so let's just deal with the principles of capnography. All right, we mentioned this before. All right, capnograph operates on the principle of infrared absorption spectroscopy. All right, which measures the concentration of carbon dioxide in your expired air by detecting the amount of infrared radiation absorbed by carbon dioxide. Now, let's look at it here. This is just the principle. We have a light source, which, the infrared light source, and this is the focusing lens, and this is your sample chamber, all right, where your carbon dioxide is present, and this measures the amount of infrared that is absorbed by carbon dioxide, all right? The infrared detector is here, and the amount of infrared that your carbon dioxide molecules have absorbed will be interpreted in the graph form, all right? And this is how it works. So a typical capnograph consists of a light source, like I mentioned, a sample chamber where your expired air passes through, and a detector. As the carbon dioxide molecules in the expired air absorb the infrared light, the detector senses the changes in light intensity, all right, which are converted into electric signals. These signals are processed and displayed as a waveform on a monitor that we know as a capnogram. Okay, now let's just move on because of time. There are different types of capnograph. We have the mainstream capnography, all right? In this mainstream capnography, the carbon dioxide sensor is placed directly in the patient's airway, typically between the endotracheal tube and the circuit, ventilator circuit. All right, the advantages of here includes that the mainstream capnograph provides accurate and immediate measurements without delay. Number two is that there's no diversion of gas from the circuit, and this prevents preserve your total airway volume. The advantage is that the sensor, which is added to your ETT, can add weight to the circuit. All right, this poses a risk of circuit disconnection or airway trauma, especially in small and pediatric patients. All right, and this sensor can also be affected by moisture, all right, arising from the expired air. So it requires regular cleaning and maintenance. The side stream capnograph, all right, in this type, a small sample of expired air is drawn continuously from the breathing circuit through a sampling tube that is attached to an external carbon dioxide sensor. The advantage here includes lightweight setup, which has minimal impact on the airway, making it suitable for non-intubated patient. All right, and this is important. This is a very good advantage. And as we're going to see, some of our non-intubated patients that we have supraglottic devices can actually have a side stream capnograph for ready measurement of your EtCO2. All right, this type of capnograph allows flexibility in patient positioning and movement, and is also ideal for long-term monitoring, especially in ICU patients and during sedation. Disadvantage includes there's always a slight delay because of the distance that the sampled air will have to travel from the sampling tube to the carbon dioxide sensor. All right, there's also a potential for water secretions to accumulate in the sampling tube, which can lead to airway obstruction and obviously affecting the accuracy of your measurement. We have other types, the microstream and the colorimetry capnography. All right, the microstream capnography uses a very low sampling flow rate, so it makes it ideal for both intubated and non-intubated patients, including the extremes of age, especially the neonates and pediatrics. All right, advantage is that there's minimal gas sampling because it uses a low sampling flow rate, and is very reliable in detecting low changes in carbon dioxide concentration, and is not as affected by moisture. Disadvantage is that it requires specialized equipment and is more expensive than both mainstream and side stream capnograph. The colorimetric capnography is very important, especially during intubation. All right, so this uses a disposable device that changes color in response to the presence of carbon dioxide. All right, it's typically placed between the endotracheal tube and ventilator. As you're passing your endotracheal tube, the color will change once you are in the right place, all right, in the trachea. It's commonly used for initial intubation confirmation in pre-hospital and emergency or resource-limited settings. It's small, portable, does not require power, all right, which makes it ideal for emergency or field settings. Provides rapid confirmation of ETT placement, all right. Now, the disadvantage is that it only offers qualitative, all right, measurement of your EtCO2 because it does not provide the capnometry, all right. It's only color change. It's limited to short-term use, as over time the device becomes inaccurate. All right, so this table just tells us the different types of capnographs, the differences in terms of sampling method, the advantages and disadvantages. All right, this slide is showing us the difference between the mainstream and the side stream capnograph. Right, in the mainstream, you can see the sensor, the capnograph sensor is placed in between the endotracheal tube and your breathing circuit. All right. While in the side stream, we have a sampling tube connected to the breathing circuit, all right, which now takes it to a multi-parameter. The EtCO2 sensors is far away from the patient's airway. And this is why some of the disadvantages that there's a delay because of the time it takes for the sampling air to move from the patient's airway to the carbon dioxide sensor. So what are the uses of capnography? I'll just also write EtCO2. All right, the E there is endotracheal tube placement. Okay, capnography has about 100% sensitivity and 100% specificity to verify correct ETT placement. Okay, so continuous carbon dioxide detention with each breath confirms that your tube is correctly positioned within the trachea and not the esophagus. The key word there is continuous carbon dioxide tracing. For patients who have had carbonated drinks, if the tube is in the esophagus, you could have some tracing, but it will not be sustained. All right, but what we're looking at here is the correct placement is continuous sustained carbon dioxide tracing on your capnograph. All right, so number two, the T there, capnograph can be used to monitor tidal volume, which represents adequacy of ventilation. So it allows for real-time assessment of ventilation. So by correlating EtCO2 values with your PaCO2, capnograph helps to assess if tidal volumes are adequate. Also, in the use of supraglottic devices, capnograph can be used to confirm that a patient who is breathing spontaneously is actually breathing. All right, so for tidal volume monitoring. Then capnograph, another very important use of capnograph is to monitor the effectiveness of CPR. In fact, most recent advanced cardiac life support guidelines recommend regular use of capnograph. During chest compression, EtCO2 values serve as a surrogate for cardiac output. So when there's a high EtCO2 level, it's a suggestive effective compression. And it has also been shown, evidence is emerging to show that your partial pressure of EtCO2 values can guide the initiation of extracorporeal life support in patients with refractory cardiac arrest. So for patients who have cardiac arrest and you're taking time, but if you can detect some amount of EtCO2, it shows cardiac output, and you can initiate extracorporeal life support for this patient and not give up on your CPR effort. There's this study that was published in Korea Journal of Anesthesiology. I found it interesting. EtCO2 can be used to detect malignant hyperthermia. Actually, a rising EtCO2 is one of the earliest warning signs. So before the patient has hyperthermia of temperature of above 40, EtCO2 will rise first, right? And this was a case report where they were able to detect malignant hyperthermia in a patient undergoing surgery, all right, because of the continual rise in EtCO2. Initially, they thought it was a malfunctioning capnograph, but when it began to rise from 55 to 70, it alerted them to the possibility of malignant hyperthermia in the absence of malfunctioning capnograph. And they were able to institute management, and the patient was saved without even using dantrolene. So capnograph can be very helpful in early detection of your malignant hyperthermia. Capnograph can also be used to detect obstruction, airway obstruction. All right, a patient with COPD, if you see here, as we're going to see, there's an increase in the alpha angle as we go on. So it can identify, it can perform real-time geometric waveform, all right, analysis to accurately diagnose COPD within minutes of breathing into the device. In fact, it's been found to be earlier. You can detect COPD earlier than your spirometry. You remember we talked about COPD in our last lecture. So using capnograph can help you to detect COPD within few minutes of patient breathing. All right. And when there's an airway obstruction, as we can see, there's a prolongation of the expiratory phase, all right, reflecting on even carbon dioxide elimination and increase in the alpha angle as we go on. So it's important for us to follow an algorithm or a systematic approach to analyzing your capnograph waveform, your ATCO2 waveform. So I devised this, is known as brush. So I'll say brush. If I give you an ATCO2 tracing, a capnograph, I want you to brush it, all right? B stands for baseline. Look at the baseline, all right, the inspiratory baseline. Is there any rebreathing? Then you look at the rhythm, all right? Is there a waveform? Is the rhythm showing uniformity? Then you want to look at the shape of the upstroke, the expiratory upstroke. Is it steep, sloping, or prolonged? Then you want to also look at the height, all right? Then you look at the expiratory alveolar plateau, looking at the shape and the shape of the expiratory downstroke. So for every capnograph tracing that you have, remember to brush, you look at the baseline to detect whether there's a breathing or not. Is it flat? You want to look at the rhythm and uniformity of the waveform, all right? Then the shape and the height. Okay, so let's look at the components. The capnograph tracing we have is the time capnogram, all right, which measures PaCO2 over time. And we have 4 phases. The baseline, like I said, look at the baseline first, okay? The baseline begins, the baseline, all right, is where there's only dead space air. There's no carbon dioxide here. So ATCO2 here is 0. This is the baseline. So a stable flat baseline at 0 or near 0 capnograph indicates proper expiration of dead space air and there's no rebreathing, all right? So the baseline is stable and flat. You look at it, all right? So this is phase 1 of your time capnogram. The second phase 2 is the expiratory upstroke. So as the alveolar gas begins to mix with dead space gas, the level of carbon dioxide rises quickly, all right, resulting in a steep upward stroke. Remember, for COPD, the slope is less, but for a normal healthy lung, right, you see a quick rise in the upstroke of the expiratory phase, all right? The slope of the upstroke indicates how quickly the patient is able to exhale carbon dioxide, all right? And a prolonged upstroke, like we saw in COPD, shows airway obstruction or there's a slow gas exchange. So this is the second phase, which is the expiratory upstroke. The third phase is the alveolar plateau, all right? This is where carbon dioxide-rich alveolar gas is expired or is exhaled. Ideally, it should be flat, as alveolar gas carbon dioxide levels are stable throughout most of this phase. So we call it the alveolar plateau. The height of the plateau, remember brush, the height of the plateau reflects the ATCO2. All right, so the ATCO2 is measured at the peak of the plateau, the alveolar plateau. Know that a sloped plateau can indicate VQ mismatch or airway obstruction, or where there is a compromised gas exchange. So it's very important for you to be systematic in analyzing your capnograph. Then the fourth phase is the end tidal point, all right, where you have the end of the alveolar plateau, carbon dioxide reaches its peak, all right, which is here. And this is where you measure your ATCO2 values. Then we have the inspiratory upstroke, when carbon dioxide levels are getting low because you're having oxygen being inspired into the system. So there are two angles in your capnograph. I hope we all take note of that. The first one is the alpha angle, all right? This angle is formed between phase 2. This is, I hope you can see my pointer here, all right? The alpha angle is formed between phase 2 and phase 3 of the capnograph. This is where the alpha angle is, all right? So it represents the transition between the ascending slope of phase 2, all right, and the plateau phase. The normal alpha angle is between 100 and 110 degrees. The clinical implication of this is that when there's an increased alpha angle above 110 degrees, it shows a condition of obstruction, either your COPD or asthma, because there's a slower release of carbon dioxide, which leads to a more slanted or a gradual increase in the slope. Let me show you what we said before. Let me see. All right, you can see here, this is a normal healthy patient. The alpha angle, this is the green one. The alpha angle is between the expiratory upstroke and the plateau. But this is for a COPD patient. There's a gradual increase in the upstroke, expiratory upstroke, and there's a bigger alpha angle. So when you have a larger alpha angle beyond 110 degrees, it shows airway obstruction. Okay, let's go. Where am I? Oh, I'm going back. Sorry. I just wanted to show you that. Okay. All right, so this is the alpha angle, the components, okay? The respiratory baseline should be 0. HCO2 should be 0 here. Also, this is the alpha angle between the expiratory upstroke and the alveolar plateau. And let's look at the beta angle. The beta angle often suggests rebreathing, all right, which is between the plateau and the expiratory downstroke, all right? So often suggests rebreathing when it is higher, all right, beta angle. All right, so this form at the intersection of phase 3 and phase 0, all right, when it's coming down. This angle normally measures around 90 degrees. So when the beta angle is increased, it suggests rebreathing. So from your looking at your capnography tracing, you can get rebreathing from your baseline and looking at your beta angle. Okay, this is what we're talking about here. So let's look at abnormal waveforms. We say when you want to analyze your capnograph, brush them. So the first thing is look at the baseline. Here, the baseline is elevated. It's not starting, it's not flat. It's not starting at 0. It's elevated, all right? It could mean one or two things. Either the patient is rebreathing carbon dioxide, so at the end of expiration, you still have carbon dioxide. This is the carbon dioxide value here. And this, sorry, carbon dioxide value here is not 0. So there's rebreathing. It could also mean, especially during, in theater, it could also mean an incompetent expiratory valve. It could also mean exhausted absorbent if you are using the circuit system, or insufficient fresh gas flow. Now we're talking about low flow anesthesia. Sometimes you may see all right, a capnograph of this nature. It may not mean that the patient is rebreathing. It may mean that there's insufficient fresh gas flow, especially when we're promoting low flow anesthesia. And sometimes it could be, those days they used to have carbon dioxide to stimulate patients' breathing. So a deliberate addition of carbon dioxide to the fresh gas flow can also lead to this. So you can have 3 to 4 reasons why you can have elevated baseline in your capnograph. All right, so this is a shark fin appearance. If you look at your shark, you see this is how their fins look like. So there's a slanting and prolongation of the expiratory upstroke. Okay, this could be due to obstruction, like we mentioned, COPD. it could be due to bronchospasm, or the EtCO2 is partially obstructed. Sometimes it can kink, so you need to troubleshoot when you see a capnograph with a sharping appearance. Is this patient having obstruction in the airway? Patient's airway or obstruction is in the ETT. So you need to do that. Sometimes this may even give you an indication to give the patient bronchodilate or bronchodilate your patient. So it's very important for you to be able to identify this. Now, this capnograph shows a coronary cleft. All right, you can see that the plateau phase is not flat. All right, there's a dip here. This shows that the patient is taking some breath. So when a paralyzed patient starts taking some breath, as the neuromuscular blockage is reversed, you'll see a deep cleft instead of having almost a flat alveolar plateau. You'll see a dip here. So it's either the neurovascular blocker is wearing out, or the patient is being deliberately reversed. So we call it coronary cleft. Now, another thing about capnograph is it's useful, all right, for return of spontaneous circulation. During CPR, when you see a sudden increase in your EtCO2, it's actually a false sign of cardiac activity. And EtCO2 more than 10 millimeters of mercury has been recommended for a successful resuscitation. And like I said, it's been incorporated into the recent ACLS guideline. Okay, so when you have EtCO2 of greater than 10, all right, it shows that there's going to be a successful return of spontaneous circulation. So capnograph has been, advised to be incorporated in all patients in which you're performing CPR, because a sudden increase in EtCO2 values is a good sign of return of spontaneous circulation. It shows that there's cardiac output in this patient. Now, if you have a sudden drop, conversely, when you're having EtCO2 37, 38, and there's a sudden drop, almost getting to 15, almost getting to 0, there are problems, all right? Like what we saw in our scenario, pulmonary embolism, or patient can have cardiac arrest. So this is a sign of cardiac arrest, and it points to you. Sometimes the cardiac arrest may precede your ECG going flat. So when there's a sudden rapid decrease in EtCO2 values, it points to cardiac arrest and pulmonary embolism. Low flow pattern, I like this, the ripple effect. All right, during the inspiratory downstroke, this is your baseline, this is your expiratory upstroke flatline, but during the inspiratory downstroke, you have some ripple effect. All right, it shows that there are some gas movement that are superimposed. All right, this pattern is usually common with patients with low respiratory rate, hypopnea. All right, when you have very low respiratory rate and you have this ripple effect. And this is important. Sometimes when for a ventilated patient, it also shows that your set frequency, ventilatory frequency, is too low for the patient. Then in kyphoscoliosis, we have what we call the double dipping, okay? All right, when you have a biphasic pattern, all right, in the plateau phase, all right? The reason is because kyphoscoliosis results in compression of the right lung most of the time, all right? And this leads to a relatively airway resistance. While the left lung exhales normally, the right lung, there's a resistance, so there's a delay in expiration from the right lung, and this is what accounts for this biphasic capnograph that you see. So this is typical of patients with severe kyphoscoliosis. All right, there are so many other ones I want you to familiarize yourself with. The time is fast spent, and we are on the top of the hour. So these are some of the things, causes of elevated CO2. Once you have the the slide, you can go over them. So in conclusion, this evening, capnography remains an invaluable tool in anesthesia intensive care medicine, playing a very vital role in enhancing patient safety and improving clinical outcome. The waveform of the capnograph provides real-time insights into patient physiology and helps in early diagnosis and intervention. These are my references. Thank you so much. I'm done this evening. The floor is open to questions and comments. Thank you. I'm trying to stop the, okay.